Everyone. So let's move to the next IC. Our IC is a pearls in the management of common eyelid conditions. So the first speaker will be Dr. Shebin, and she'll be dealing with troublesome lid margins. She's a consultant working in Giridhar Eye Hospital.
Very good morning to all. So I'll be starting with the lid margin. So we all know that lid margin is a very small structure, only 2 millimeter wide, but it contains a variety of structures which have various complex anatomical and physiological functions, including the barrier protection, ocular, forming the lipid component of the tear film, and equally distributing the tear film across the ocular surface. So let us start with the anatomy. So most anteriorly we have the lash line, then comes the gray line, the meibomian gland orifice, the mucocutaneous junction, and the lid viper. So we have many glands in the lid margin, including the gland of Sees, which is a modified sebaceous gland, gland of Mole, and meibomian gland. So let us start with the first trouble, that is a blepharitis. So marginal blepharitis can be divided into anterior blepharitis, that is the inflammation of the lash root and follicle, and posterior blepharitis, which is the inflammation of the meibomian gland and the posterior lid margin. The most common cause of anterior blepharitis is Staphylococcus aureus infection, and this is also associated with systemic conditions like seborrheic dermatitis and rosacea. Posterior blepharitis could be due to meibomian gland disease, conjunctival inflammation, or acne rosacea. So one thing we have to remember is all MGD is not posterior blepharitis. Only when meibomian gland disease is associated with the inflammation of the posterior lid margin, then we call it as posterior blepharitis. And also a detailed history taking is important, because many of the systemic medications, including the taxanes, antimetabolites, they can all cause a meibomian gland dysfunction sometimes and with blepharitis. So clinical features can vary from itching, burning sensation to foreign body sensation. The signs, we can broadly divide them into lid margin signs and tear film and ocular surface signs. So we have lid margin erythema, sometimes edema, these fine telangiectatic vessels. Then there can be collarets or scales at the lash roots. Then this is a classical sign of meibomian gland disease, the inspissated meibum you can see, and on pressure you can see this cheesy material coming out from the meibomian glands. Then ocular tear film signs, we have the frothy tear film, then a reduced tear film breakup time, the associated conjunctival congestion and corneal SPKs. There can be even corneal scarring and vascularization in severe cases. So regarding treatment, the conservative treatment, we all know about this lid hygiene, the oil scrubs, then topical ointments. But what we have to remember is we have to educate the patient. That is the most important thing, because if we just tell them warm compress, they will think that they are taking bath in warm water, so that is adequate. No, that is not adequate. We have to clearly tell them how to keep the warm soaked cotton or for 10 minutes or 5 to 10 minutes, and how to scrub the lid correctly. That is the most important thing. So a word about Demodex. So this Demodex is an ectoparasite that is commonly seen even in normal asymptomatic individuals. But when they increase in their density, also known as demodicosis, they can cause hypersensitivity and inflammation and blepharitis. So this characteristic collar-shaped, collarate, cylindrical-shaped scales that is seen in Demodex infection. So this is one new drug that is coming, which is known as lotilaner. This is a parasite-specific gamma aminobutyric acid chloride channel inhibitor that is in the last phase of clinical trials. Then regarding theriasis palpebrarum, this is pubic love. So these patients, when they present, we have to spend more time. Ideally we have to remove each lice and knit with a non-tooth forceps, and always you can give some topical ointment for lubrication. Oral ivermectin is also effective. Hordeolum internum and externum, this we all know. Acute bacterial infections of the meibomian gland, that is internum, the Sees and Mole gland, that is externum. So here in the second picture we can see that there is pus pointing at the lash root. So that is a classical sign of hordeolum externum. And in some cases of hordeolum internum, the presentation can be very subtle. Patient present with some mild pain, mild lid edema, there will not be any classical feature of internum. But if we evert and see the lid meibomian gland orifice, you will see some kind of edema, erythema, and some purulent discharge from the meibomian gland. So that is another sign to differentiate early. Then chalazion is chronic sterile lipogranulomatous inflammation. So this is incision and curettage for chalazion. This we all know, we all do this. But what I want to highlight is it is always important to remove the capsule of the chalazion, because for two things. One is there can be a recurrence if you don't remove it completely. Second, if we keep it there, most of the patients will be satisfaction will be less, because there will be some amount of residual thickening. So it is better to remove it. This is something LipiFlow. It is conventionally used for the meibomian gland disease, but this can also be used in case of patients with the recurrent chalazion chronic MGD. So this is very easy to use, and only the cost is a problem. So we have the eye cup here. This is the lid warmer which will be kept inside the eye. So this will generate heat, and through the conjunctivitis transmitted to the meibomian glands. And this is the eye cup that will apply pulsatile pressure to the eyelids, so to express out the meibomian gland secretions. So next, this is something known as microblepharoexfoliation or BLEPHEX. So this is a rotating light bar with a medical grade micro sponge. So this will gently and accurately spins along the lashes and eyelids to remove the debris and the biofilm. So this again is can be used for both blepharitis and chalazion. Then we have the intraductal meibomian gland probing, first introduced by Maskin. This is a Maskin's probe, but this is a cumbersome procedure, but found to be very effective in case of obstructive MGD. So here we have to anesthetize the lid margin, and with the probe we have to probe through each of the meibomian gland opening. So this is a meibograph image showing the probe within the meibomian gland. Then we have intralesional triamcinolone acetonide injection. So this again we don't usually prefer, because there can be some complications including fat atrophy, depigmentation, and very rare chance of visual loss. So want to point one under recognized entity, that is meibomian gland invasion. So this is it is an early change before the onset of cicatricial marginal entropion. So here we can see that the meibomian gland is inverted. So especially if there is associated keratinization, this can cause a lot of symptoms to the patient, including foreign body sensation, grittiness. So if the patient is symptomatic, we can treat them with the surgical intervention, lamellar repositioning. So cyst of mole and cyst of cyst, all of you know. So intervention, if the patient prefers, and also if the size of the lesion is increasing, we can remove it. Now coming to the next set of issues, that is with the lash. So here we can broadly classify the lash abnormalities into three, that is with the direction and position, pigmentation and growth. So mainly we will be concentrating on the direction and position, that is trichiasis and distichiasis. Trichiasis could be either primary, when there is misdirection of the hair shaft, secondary when it is associated with due to secondary to entropion, and distichiasis abnormal row of lashes. So distichiasis could be either congenital or acquired. It can be isolated or could be syndromic also. So for trichiasis and acute distichiasis, these are the common etiologies: chronic blepharitis, trachoma, chemical thermal injuries. Most importantly, what we have to remember is any cicatrizing conditions, that because we should keep in mind while examining the patient also. So how to evaluate everything: lid margin position, how many lashes are misdirected, is it single, group of lashes, where is the root location, is there an associated inflammation of the lid margin, and especially shortening of the fornix, symblepharon formation. So this will entirely change your management plan. Now, again, diagnosis is not a challenge here, but we have to detect the other associated abnormalities. So goals of treatment: preservation of vision, comfort, and acceptable appearance of the eyelid. So we can broadly classify the management into removal procedures and repositioning procedures. So if only trichiasis, we can go ahead with a lash removal or ablation procedures. But when there is an associated entropion, we have to go for a lid margin rotation technique or an anterior lamellar recession. But if there is a lid margin or a posterior lamellar scarring, then the mucous membrane graft should be put. So the only thing what we usually do is radiofrequency ablation. So this is done under local anesthesia. The depth is important. In upper lid, you have to go around 2.4 millimeter, lower lid 1.4 millimeter. So the radiofrequency pulse is applied for 5 to 10 seconds. So again, there is a chance of recurrence in radiofrequency ablation also. This can be combined with mitomycin C for a better result. Argon laser we don't use commonly. Cryotherapy is also not preferred because of many complications including depigmentation, new trichiatic lashes, conjunctival migration, lid margin notching. So this the trephination of the root with a cissless microtrephine can be done in cases of few trichiatic lashes or in case of a recurrence. This is also very effective because we are removing the entire root. A pentagonal wedge resection can be done in those cases, especially following a trauma when there is some lid margin notching is there, or for a focal trichiatic lesions. So, and again, if there is an entropion, an anterior lamellar repositioning and lid split can be done, especially in case of overhanging anterior lamellae. But when there is a cicatricial changes, we have to put the mucous membrane grafting. Yeah, thank you. I think doubts we can keep to the end of the session. Thank you so much.
I invite the next speaker, Dr. Marian Poli. She needs no introduction. She'll be talking on lumps, bumps, and beyond.
Hi, good morning. I'm very happy to see such a crowd. So I'm just thank you, Dr. Shebin, for putting such a wonderful basic IC, which we all should know. So this is lumps, bumps, and beyond. So in this, I'm basically have put only pictures, no text at all. So how we differentiate the dangerous ones primarily. Slideshow. So I basically, in my practice, I basically look at the color. So that is like basically categorized into red lesions, yellow lesions, black lesions, white or gray white lesions. So this is my color coding for the lid lesion. So I thought with a small introduction. So there are some 10 pearls which I always look into all the lid tumors. Even if I'm 100% sure this is benign, and always look into all these 10. That is loss of lashes, tarsal thickening, closed meibomian gland orifices. So this meibomian gland orifices, if it is closed, then I press. Because it can be closed with the pus, it can be closed with the tumor. So when you press, if the orifice is opening, okay, fine, you are dealing with something benign. Okay. So then loss of normal architecture. So we have seen the normal architecture of the eyelid margin from Dr. Shebin's presentation. So anything, either rounding of the posterior margin or some loss of lashes or thickening, anything, something of loss of normal architecture. Then surface telangiectasia, that I will come later with the pictures. Then surface ulceration, irregular surface, ectropion, then irregular pigmentation. Usually if you see black, everything should be uniform color. But in some area it is black, some area it is gray, some area it is white. So that means then you have to be really suspicious. So irregular pigmentation, then color of the mass I have already told, and finally preauricular lymph node. So now let us start with the cases. So now we can see pointer. So now you can see a yellow lesion involving the both upper lid and the lower lid. Yeah, so both upper lid and lower lid. It is actually raised, yellow in color. So is it okay? So then she has got some surface inflammation. So is it so in this I having like, is it sandilasma? That is my question number 1. Or is it something that is dangerous? So look at, so now you can see this raised, and there are multiple, almost extending up to the like multiple lesions. So this is very unlikely to be a dangerous one. So this is sandilasma. So now again look at it. So you can see there are multiple lesions here, 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 here. So this is something like benign. This is sandilasma. So now this is another lesion. So look at it. Is it a part of the skin color or something that we have to be little worried? In the down gaze, you can see again a little bit of yellowish discoloration. Patient came only for this, and he says he's getting occasional lid edema. Anyway, from the previous picture, we know this is not sandilasma, though this is something else. So this is actually a case of xanthogranuloma. So xanthogranuloma you have to be really taken care of, because it can be associated with hematological malignancies. You need to do biopsy to confirm and get a hematologist opinion, etc. So what about this? So again, xanthogranuloma. I mean, if you look, you can ask patient. Patient is complaining is really puffy looking eyelid. He's not really bothered about the disease which he is having. So actually, when I told him, this is xanthogranuloma. So when I told him you need biopsy, etc., etc., he was also laughing at me. He actually came for a cosmetic surgery. Okay, so this was a case of xanthogranuloma, and he had systemic association, and he is under care of hematologist now. So now we'll see another lesion. You can see multiple lesions, but not the color is little different. So this is not pure yellow. It has surface is little irregular. Then yellow is not really uniform. In between, some red is there, some red yellow is there. So this is again a case of xanthogranuloma. But her history was she's already a known case of xanthogranuloma. So for us, this diagnosis was more or less quite straightforward. So now move to another set of yellow lesions. So now look at this lesion. So again a yellow lesion. She just came for a kuru, that is a kuru. So now again look into all the 10 pearls which I have told. So that is loss of lashes, closure of the meibomian gland orifice. Now look at this. So it is extension to the tarsal surface. See the posterior lid margin, see the anterior lid margin, the normal architecture is lost. So this is not a normal kuru. This is something that we have to be really careful. It is a case of sebaceous gland carcinoma. So this is again another case. So if you look in the torsal lid examination, just a small thickening, but there is no definite loss of lashes. So you can be really mistaken for like some benign pathology. But so when you see like always all the lid lesions, especially in the lid margin lesions, evert the lid and see. So now when you evert the you can see this is a clear-cut case of sebaceous gland carcinoma. So this is again I'm showing different spectrum of SGC. This is nodular. Again, if you look at it, she has got all the features: loss of lashes, then surface telangiectasia, loss of normal architecture, tarsal plate extension, etc. What about this? Is it a lid abscess or is it a large chalazion or chalazion with the granuloma? So now that I hope everybody will be able to, yeah. So this is a clear-cut case of she has got all the features of sebaceous gland carcinoma. So now spectrum of yellow lesion is over. Lid abscess I have not put because Dr. Shebin has already shown. So this is a spectrum of lesions which we have to be really taken, really look into it. So now come to the brown black. This is again a very tricky areas. So this is the patient just presented with mass in the upper eyelid. Look at it. This is we are seeing on a routine basis on every day. So if you look at margins are well defined, surface is like more or less a uniform color, no ulceration, no telangiectatic vessels. So this is a case of seborrheic keratosis. Surgery can be done for aesthetic purpose, and if it is obstructing the visual axis, it improves the vision also. So now what about this? So she just presented with some bleeding from the eye when she rubs. So here is a little borderline. You can see some irregular margins, but if you look here, she had something like papilloma, and she had itching, and probably during that time it got broken off. But sparse lashes are there, but there is no full loss of lashes. So this is actually a case of inverted follicular keratosis. This is again you have to be very careful. This is a pre-malignant condition, so it needs treatment. So now comes the another black lesion. This is, if you look at it, there is just a black lesion. He says it is there since 7 years. Now it is slowly growing. But he has consulted many places, and even the cataract surgery has been done. So now look at the each edges. It is not normal. It is rolled out. Look at the surface pigmentation. Here it is like black. Here it is little less black. That is little white. And lashes is more or less okay. edges is rolled out, surface is also irregular. So this is a case of basal cell carcinoma. So here also when I told need surgery, then he was like, no, it cannot be a problematic mass. This is us in 7 years. So we can actually get very difficult to convince the patient sometimes you need a treatment. This was a case of basal cell carcinoma and he later underwent wide excision and reconstruction. So what about this? Just a small black mass. I'll just finish in 1 minute. So look at each characters, again surface ulceration, rolled out edges, etc., loss of lashes, again basal cell carcinoma. So this is papilloma. Here there is no signs of malignancy. What about this? Clear cut now, basal cell carcinoma. So now look at it. It's a nevus which we come across. So what are the surface features? You can see some intrinsic vascularity. Why? Because it is the pigment is less, that's why we are seeing all these vessels. But there is no ulceration, no loss of lashes. You can see the lid margin is like intact and posterior margin is also intact. This is a junctional nevus. So this is very common, that is umbilical lesion, that is molluscum. Here this is it chalazion or not? So this is not a chalazion. Look at the tarsus. So there is no inflammation, and from the history also patient doesn't give any history of inflammation. So this is a case of tarsal cyst. It needs complete excision, otherwise it will recur. Mole cyst we have seen. Is it again tarsal cyst? So this is not a dangerous one anyway. This is sebaceous adenoma because red. I'll just this is hemangioma. Again this is this again I thought of something problematic, but because if you look at the margin is thickened, it is raised and it is highly red. This was a little atypical case of amyloidosis. Unusual lesions I just put across. This is was a case of adnexal carcinoma. You can see the surface ulceration and pigmentation. He is history bleeding in between. This is like you can see surface calcification, pigmentation, telangiectasia. Again, this is pilomatrix carcinoma. So adnexal tumors can sometimes make you fall. This is also a case of mucinous adenocarcinoma because look at the surface, pigment, telangiectasia, etc. So again, 10 pearls from my talk. Always keep in mind, and thank you so much.
Thank you, ma'am. Thank you so much. I guess now we can differentiate between to some extent, between the benign and malignant lesions. So next we have Dr. Navina Shashindran talking on ectropion and entropion, getting the lid straight. So she is the assistant professor of ophthalmology at Alappuzha Medical College. Welcome, ma'am.
Good morning, everyone. First of all, I would like to thank Dr. Shebin for giving me this opportunity. So today my topic is entropion and ectropion, getting the lid straight. Okay. So first of all, what are the anatomical factors that are keeping our lid straight? They are the horizontal attachments by the medial and lateral canthal tendons, and the vertical and anteroposterior forces exerted by the orbicularis muscle and the retractors of the lid, which will keep the tarsal plate straight. So entropion is inward turning of the lid margin. So what is the main pathophysiology behind entropion? Here there is laxity of both medial and lateral canthal tendon, which will result in loss of horizontal support. Also overriding of preseptal muscle over the pretarsal orbicularis. Here you can see the lax lower lid retractor, which causes outward turning of the lower border of the tarsal plate, and also the atrophy of the tarsal plate leading to inward turning of the upper border of tarsal plate. So the lid can turn either in or out depending upon the changes in the orbicularis, lower lid retractors or tarsal plate. Coming to classification of entropion, it can be congenital, involutional, which is the most common type, then cicatricial and spastic. So what brings the patient to the ophthalmologist? It is a foreign body sensation, redness and watering, and these are secondary to corneal irritation by the lash or the keratinase conjunctiva. How to evaluate these patients? We have tests for horizontal laxity such as pinch test, snapback test and horizontal distraction test. So here in pinch test, we are pulling the lid away from the globe, and we are assessing how far we can pull the lid away from the globe. So if it is lax, it will be, we can pull it. If it is more than 6 millimeter, it is considered as horizontal lid laxity. Then snapback test. Here we are pulling the lid downwards and slowly releasing it. So in normal cases it will immediately snap back, but delayed in case of horizontal lid laxity. Medial canthal tendon laxity. Here we are assessing the degree of punctal displacement by giving a lateral traction to the lower lid, whether it is coming up to the medial limbus or up to the pupil. Lateral canthal tendon laxity, you have to note the rounding of lateral canthal tendon. Then the test for lower lid retractors, we have to ask the patient to look down and see for the lower lid excursion. Normally it will move around 4 millimeters. In case of retractor laxity, it won't move. And also we can notice a white subconjunctival line of detached retractors in the inferior fornix. Ask the patient to squeeze and release to test for orbicularis muscle. Now coming to management of involutional entropion, it can be temporary methods or permanent procedures. Temporary methods include sutures, taping and botox, and permanent procedures will be dealt in detail. So temporary sutures can be either transverse or reverting sutures. So both will prevent overriding of preseptal muscle over pretarsal orbicularis, and these are mainly indicated in geriatric patients and patients having bleeding disorder. In transverse suture, the bite is taken from the conjunctival side just below the tarsal plate and it passes transversely and emerges at the skin side, and it is useful in case of spastic entropion. And in everting sutures, here it will take care of the lower lid retractors, and also it will transfer the pull to the upper border of tarsal plate. If entropion is not associated with any horizontal laxity, then we have V's procedure. Here the full thickness lid split is given transversely, which will create a fibrous scar that prevents the overriding. It is combined with everting suture, which will transfer the pull to the upper border of the tarsal plate. If entropion is associated with lid laxity, then a horizontal lid shortening is also indicated. So the above V's procedure can be combined with horizontal lid shortening, that is Kuckert procedure. Now in case of recurrence or retractile laxity per se, we have Jones procedure. Here we will take care of the retractors. We will plicate and shorten the retractor, and also the fibrous scar will prevent overriding. So this is summary of involutional entropion. If we are not having any horizontal laxity, we can either go for a temporary method or a permanent procedure. If we have horizontal laxity, a Kuckert procedure can be done. If there is recurrence, Jones is advocated. Now coming to cicatricial entropion. Cicatricial entropion, the main pathology lies in the posterior lamellae, that is the tarsal plate and the conjunctiva. So in case of lower lid cicatricial entropion, here we are assessing the lower lid retraction below the limbus. If it is less than 1.5 mm, it is considered as mild, and if it is more than 1.5 mm, it is severe. So in mild cases, we can do tarsal fracture and everting suture, and in severe cases, we need a posterior lamellar lengthening using a graft. Upper lid cicatricial entropion, the management depends upon the severity of the entropion, the tarsal plate thickness, the keratinization of conjunctiva, and lid retraction. So if it is mild, we can go for anterior lamellar repositioning, where the anterior lamellae is sutured high up in the tarsal plate. And if it is severe, depending upon the tarsal plate thickness, we can have tarsal wedge resection if the tarsal plate is thick, as in case of trachoma, and posterior lamellar division and graft placement, as in case of thin tarsal plate in ocular pemphigoid and Stevens-Johnson syndrome. In case of keratinized tarsal conjunctiva, you can rotate the terminal tarsus outwards, which will prevent the corneal irritation. If it is severe lid retraction, then a posterior lamellar graft is indicated. Now coming to spastic entropion, which is secondary to mainly inflammatory diseases of eye or any recent ocular surgery. And the treatment is taping of lids or Botox injection. Congenital atropion, always rule out epiblepharon before going for any surgical intervention. In epiblepharon, there is no actual inward turning of the lid margin. Congenital atropion can be managed by Holt's procedure. Here, an ellipse of skin and orbicularis is removed just below the punctal area, and the lower lid retractors are sutured to the lower end of tarsal plate. Now, coming to ectropion. Ectropion is outward turning of the lid margin. The symptoms are similar to entropion, like redness and watering, and there will be inability to close eyes, and there will be associated features of facial nerve palsy if it is a paralytic ectropion. And these features are secondary to corneal exposure, tearing, and keratinization of conjunctiva. Ectropion can be classified as congenital, which is rare, and acute can be involutional, paralytic, cicatricial, and mechanical. So, management of ectropion should address the following 6 pathological elements. Now, management is mainly based on the segment of the eyelid involved. So, it can be generalized ectropion or medial ectropion or lateral ectropion. In case of generalized ectropion with horizontal laxity, a horizontal lid shortening is indicated. Here, a pentagon shaped lid margin is excised and sutured directly. It can be also managed by another procedure known as lateral tarsal strip. Here, a full thickness incision is given at the lateral canthal area, an inferior cantholysis is done, and a lateral tarsal strip is fashioned out, removing the anterior lamellae and the posterior conjunctiva, and this strip is attached to the periosteum. So, the advantage over horizontal lid shortening is that there is no sutures over the lid margin. Now, if ectropion is associated with horizontal lid laxity and excess skin, then this excess skin muscle flap has to be removed by Kuhn-Siemnowski procedure, in which we will do a horizontal lid shortening and blepharoplasty. Now, medial ectropion can be either punctal eversion alone, or it can be associated with medial horizontal laxity, or it can be medial canthal tendon laxity. If it is a punctal eversion alone, it can be managed by excising a diamond-shaped tarsoconjunctiva below the punctum and suture it vertically, which will invert the lid. So, thereby we are shortening the medial posterior lamellae. If it is associated with medial horizontal laxity, a LACT procedure is indicated, where we will do horizontal shortening at the medial end. In medial canthal tendon plication, the medial tarsal plate is identified and it is sutured to the medial canthal tendon insertion. Coming to paralytic ectropion, it can be managed by either temporary or permanent methods. Temporary includes taping of the lid, lubricants, and permanent includes lateral tarsorrhaphy. And another method is medial canthoplasty. Here, raw area is created medial to punctum in both upper and lower lid, and it is sutured directly, taking care of the canaliculus. Lateral canthal tendon laxity can be managed by lateral tarsal strip, as explained before. Cicatricial ectropion, the main pathology lies in the anterior lamellae. So, if it is a local linear scar, we can go for resetplasty, where 2 skin flaps are transposed to increase the length of the skin along the scar line. In diffuse scar, we can go for either skin flap or skin graft. In case of skin graft, full thickness skin grafts are preferable. Mechanical ectropion, always remove the cause and treat any associated laxity. So, to summarize, in case of involutional entropion, if it is medial, punctal eversion alone, you can do medial conjunctivoplasty. If it is associated with horizontal laxity, LACT procedure is advocated. Generalized ectropion, it can be managed by horizontal lid shortening or lateral tarsal strip, and in case of lateral ectropion, lateral tarsal strip alone. And in paralytic ectropion, you can go for medial canthoplasty or lateral tarsorrhaphy. Cicatricial, depending upon the type of the scar, you can manage, and mechanical ectropion, treat the cause. So, to conclude, knowledge of basic anatomy and proper counseling is essential for the best results. Thank you.
Thank you, ma'am. Thank you for that elaborate discussion on entropion and ectropion. Next, we have Dr. Indu B. Narayanan. She is a consultant oculoplastic surgeon at Comtest Hospital. She will be addressing to lids, what to do.
Good morning, everyone. Thank you, Dr. Shabin, for giving me this opportunity. So, this is not a very uncommon condition, twitchy lids, and often it is very debilitating for the patient. So, let me begin with the anatomy, very relevant anatomy. What do you think are the muscles that are required when a patient closes his eye? So, there is the first and the foremost, it's the orbicularis, which comes into action. Contraction of the orbicularis. And all of us know that there are two parts of orbicularis. It's the palpebral and the orbital part. So, the orbital part, can I have the pointer please? So, this is the orbital part which covers the beyond the orbital rim, and this is the palpebral part which is divided into pretarsal and the preseptal. So the palpebral part, it helps in the normal closure, and the orbital part, it helps in the forceful closure of the lid. And it's not just the orbicularis which acts on closing, it's also the levator. The relaxation of the levator causes the closure of the eyelids. So this is a very pretty common condition. This is called as the orbicularis myocymia. Here you can see that there is transient flickering of the lower eyelid, and it's usually commonly seen in the young individuals. There is spasm of the single muscle fiber or a bundle of muscle fibers. So the myocymia, what is the main cause for myocymia? It's often the stress, lack of sleep, and excessive intake of caffeine or the alcohol, tea. So how do we counsel the patient? It's a benign condition. It's not, there is nothing to worry. It's usually resolves by self, and you can ask the patient to have good sleep and reduce the tea intake or caffeine intake, and often the lubricates helps to a minimum. Is botulinum toxin indicated in such cases? Only when it is very severe, I mean in chronic conditions where it is more than 3 months or so, if it persists. So next, video please. Yes, this is a 65-year-old lady. It's called as the benign essential blepharospasm. So what is it? It's involuntary, repetitive, progressive muscular orbicularis contraction occurring. It's mainly common in females, more than that means more than 50 years. So this often starts with excessive blinking or photosensitivity. It often starts in one eye, but finally it ends as a bilateral condition. This I was actually, when I was taking the videograph of the patient, I was not able to get the spasm. I couldn't, because the patient was deeply concentrating, and on concentration it disappears. Okay, so this disappears on concentration as well as in sleep, and the diagnosis, it's always clinical. It doesn't require any imaging here. So what's the management? The lubricants or the tinted glasses and some of the medications such as antidepressives or anxiolytics, they are of not much use. And this is what happened to the patient. Play the video. Yeah. So what is the wonder drug? All of us know it is the botulinum toxin. Botulinum toxin type A, it's an exotoxin, and it acts by the mechanism of chemodenervation. It acts as the neuromuscular junction, and it blocks the release of acetylcholine. So it's commonly available in the dry powder form, and it's constituted with preservative-free normal saline. And the concentration of botulinum toxin that we inject in functional conditions, it is 2.5 international units per 0.1 ml. So this botulinum toxin is usually available in 50 units or 100 units, but the final concentration that we make is 2.5 international unit for the functional indications. So these are the common sites of injection used for blepharospasm. You can see it is the pretarsal orbicularis is targeting the pretarsal orbicularis, and also one point which is 1 centimeter lateral to the lateral canthi, and oftenly the corrugator superciliaris. Sometimes even the procedures may also be involved. We need to give at that point. So what are the sites which are avoided? This one, that is the central part of the upper lid, because it causes ptosis. It may involve levator and it can cause ptosis. And the lower part of the medial part of the lower lid, because it causes the ectropion. So the action of Botox, it usually starts within 3 to 5 days and peaks within like 3 weeks. It lasts only for 3 to 4 months. It is due to regeneration of the new axons. So there are very few contraindications for botulinum toxin. It's pregnancy, lactation, and other neuromuscular disorders. So this is the next condition. Play the video, please. So this is hemifacial spasm. It's a unilateral, you can see that unilateral involuntary contraction of the muscles which are supplied by the seventh nerve, and it's common in the middle-aged. The cause here is that it is the vascular compression which causes compression over the axon of the seventh nerve when it comes out of the brain stem. And sometimes very infrequent, it's 1%, less than 1%, it is due to posterior fossa tumors. So a neuroimaging MRI with MR angiogram is very essential, unlike the other one, blepharospasm. And the definitive treatment is microvascular decompression procedures. So, and hemifacial spasm, the sites are almost the same regarding the upper part of the face, but when it comes to the lower part, we target at the zygomaticus major, ask the patient to clench the teeth, and then also the depressor anguli oris. Sometimes the mentalis may also be injection is required to that point. So what are the what do we give instruction to the patient? Do not rub the face or do not lie down in the very 1 to 4 hours, because it can cause a gravitation and cause the side effects. Always avoid heavy exercise and alcohol following a day. So here you can see that this lady, there is no much spasm, but you can see once she closed the lid, she is unable to open it up. And it is with her mechanically she has to lift up the lid. What is this condition? It is the apraxia of lid opening. It's basically the difficulty in initiating the lid opening after closure. This is often very difficult to treat comparatively rather than the other two conditions. And in severe cases of apraxia, initial treatment will be the botulinum toxin only, but in some cases which is very refractive, you may have even to go in for a surgical myectomy. So in myectomy, here the surgeon is putting a blepharoplasty incision, and the skin with the orbicularis is excised. Here mainly the pretarsal and the preseptal, that is the palpebral part of the orbicularis, is removed. Not always here you can see that the pretarsal and the preseptal part, that is the palpebral part of the orbicularis, is removed, and not always the orbital part is only removed in very certain conditions. So just to summarize this, blepharoplasty incision, then the skin along with the orbicularis is taken, that is the palpebral part. So here you can see that the pretarsal orbicularis, it is separated from the tarsal plate and the skin, and finally the preseptal part is also removed. So with that I conclude. Thank you.
Thank you, Indu. Thank you so much for that extensive discussion. Next, we have our guest faculty, Dr. Manju M. She is a consultant dermatologist and cosmetologist at Sunrise Hospital, Kochi. The talk is on all about dark circles.
Good morning, everyone. I thank Dr. Shebin and the Drishti organizers for giving me this opportunity. The topic assigned to me is dark circles or periorbital melanosis. So this is the disclaimer. And periorbital melanosis, also known as dark circles, periorbital hyperpigmentation, periocular melanosis, and idiopathic cutaneous hyperchromia of the orbital region. This is a very short presentation. In this presentation, I'll be mainly discussing the different types of periorbital melanosis and how to differentiate and what are the treatment options available. It can affect both sexes, young and old. Sometimes it can be familiar, usually bilateral with one eye involved more than the other. It can affect the upper eyelid, lower eyelid, or the both. Classification, mainly 4 major types, but there are other types also. The main types are constitutional, vascular, structural, and post-inflammatory. This is the constitutional type. In constitutional, the pigmentation is confined to the orbital margin, present as a curved band of brownish to black hyperpigmentation of the lower eyelid skin along the shape of the orbital rim. It can also affect the upper eyelids also. Then vascular, when there is prominence of the vessels in the periorbital area, this is a cause of vascular type of dark circles. Then structural, it is mainly due to the shadowing effect of the tear trough or the fat herniation. With aging, there is laxity of the lid and cheek junction, and there is herniation of the fat pads. Post-inflammatory, when there is pigmentation secondary to atopic dermatitis, allergic contact dermatitis, or fixed drug eruption, we call it post-inflammatory pigmentation. In the initial stages, that will present as erythema, and later when it heals, it can leave the pigmentation and it can present as dark circles. Coming to the other causes of periorbital melanosis, it can be an extension of pigment demarcation line. Pigment demarcation line means there's a clear line of demarcation between the hyperpigmented area and the normal skin. When there are different types of pigment demarcation lines in our skin. When it involves the periorbital area, it can be a V-shaped pattern or it can be a W-shaped pattern. In the first picture, you can see the V-shaped pigmentation in the periorbital area, and in the second picture, you can see the W-shaped pattern. This patient has the W-shaped pattern of pigment demarcation line with a tear trough. Tear trough is the medial 1/3 of the periocular sulcus. When there is presence of dermal melanocytes in the periorbital area, it can be a cause for dark circles. This is a picture of nevus of aorta. In this picture, the patient has bluish black pigmentation involving the periorbital area along with involvement of the sclera. Then lichen planus pigmentosus is a type of lichen planus present as bluish black pigmentation. Any part of the body can be affected. When it occurs over the face, it can also present as pigmentation around the periorbital area. Next, melasma. When the melasma present in the periorbital area, it's also another differential diagnosis for dark circles. Then periorbital acanthosis nigricans. Acanthosis nigricans present as hyperpigmented velvety plaques over the flexures and the neck, and sometimes it can involve the face. When it involves the face, there will be a velvety texture over the eyelids also. Certain drugs like hydroquinone, estrogen, NSAID, bimetoprost and latanoprost can induce the periorbital pigmentation. Systemic diseases like thyroid, Addison's disease, anemia, lifestyle changes like smoking, alcohol, lack of sleep, and stress can also induce the dark circles. Another most important thing is photo damage. When there is excessive UV exposure, that will lead to the oxidative stress, and there will be pigmentation around the eyes and also laxity around the eyes. Then how to differentiate when a patient steps in with a periorbital melanosis is a very simple technique. Just manual stretching of the lower eyelid, we can differentiate whether it's a true pigmentation or the shadowing effect. When we stretch, if the pigmentation is remaining like that, it's a true pigmentation. When we stretch, the pigmentation is disappearing, it's a shadowing effect due to the tear trough or the other structural anomalies. When there is increased violaceous discoloration when we stretches, can be due to the vascular prominence. In this video, when we stretches the lower eyelid, the pigmentation is remaining. So it's a type of true pigmentation. And by using Wood's lamp, we can differentiate whether it's an epidermal pigmentation or a dermal pigmentation. In epidermal pigmentation, the pigmentation will be more evident with Wood's lamp, and in dermal pigmentation, the pigmentation will be less evident. Coming to the treatment, the dark circles are a little bit challenging to treat. It lacks a straightforward and a repeatable therapeutic option. What we usually practice is a multimodality treatment that will be more efficacious and long lasting. And the most important thing is we have to find out the cause. In the treatment part, the sun protection is very, very important. Sunscreen, even if you are sitting indoors, we have to apply the sunscreen. Before 9 o'clock, we have to apply the 9 to 4, the UV light is causing more damage. So before 9 o'clock, we have to apply the sunscreen, and it's better to reapply the sunscreen every 3 to 4 hourly. And we can also use the sunglasses. These are some of the topical treatment options, and we can the topical agents containing alpha-arbutin, kojic acid, azelaic acid or retinoic acid we can use. When the topical treatment fails, we can plan chemical peeling. We can use the trichloroacetic acid peel, glycolic acid peel, lactic acid peels in the periorbital area. Usually we need repeat sessions. Next treatment option is lasers. When the treatment fail in terms of the topical treatment and the chemical peeling, we can try the periorbital laser toning. As a part of periorbital rejuvenation, we can also try microneedling, PRP injections or CO2 laser treatment. When there is skin laxity and tear trough, we have to inject the hyaluronic acid fillers or the autologous fat transplant. In case of periorbital fat herniation, we have to do blepharoplasty. So coming to the approach, when a patient comes with periorbital melanosis, what I usually practice is first we will differentiate whether it's a true pigmentation or it's a structural. And if it is a true pigmentation, first we'll give the topical treatment. We can give the topical treatment for 1 or 1.5 months. If there is no improvement, we can advise regarding chemical peeling. Chemical peeling, usually we do 2 to 3 sessions of peels in 2 weekly interval. If there is no response and if the patient is willing, we can go for laser toning treatment. And if it's a vascular pigmentation, lasers will work. And the structural, we have to do fillers, fat transplant or blepharoplasty. Some of the procedure videos. This is the chemical peeling. We can apply the peeling solution after cleansing the area and wait for some minute, and then we'll neutralize. Next, laser toning. Before doing laser toning in the periorbital area, we have to protect the eyes with the metal eye shield. And before placing the metal eye shield, we will usually anesthetize the area with using the topical anesthetic solutions. And then we'll place the metal eye shield. After that, we can do the laser toning. It's a painless procedure, very simple. This is the micro needling. We use the derma pen. We are creating micro injuries around the eyes, and the micro needling can also be used along with PRP as a part of rejuvenation. So the take-home message is, the main thing is we have to educate the patient. It's a chronic condition. Strict UV protection is needed, and the patient has to stick to the prescribed treatment. It takes time to see the result, and the continuation of treatment is very important when you see the result, and the multimodality treatment works better. Thank you. Thank you so much.